a shift in CRT practice. 2-lead CRT DX proven non-inferior to conventional 3-lead CRT D. Could you outline the clinical background and objective of the CRT NEXT study?
This is a study focusing on CRT patients, and the aim was to explore whether a dedicated atrial lead is strictly necessary in CRT recipients, based on the concept that in left ventricular systolic dysfunction, the heart rate role is so clearly pointing that the lower the better, that you don't need atrial pacing support. So we engaged 24 Italian centers willing to participate into a randomized clinical trial, testing whether a 2-lead system providing atrial tracking only and not atrial pacing would lead to comparable clinical results and reliable system functioning compared to a 3-lead customary system. Turns out that the non-inferiority endpoint was met, and indeed the 2-lead system, the DX CRT D device, had significantly lower atrial lead related complications compared to the 3-lead system, while the clinical endpoint were comparable. So in the end, we were very happy because the majority of patients in the CRT DX arm had a perfect clinical outcome without atrial lead related complications.
What are the key messages that emerge from the study results and that you consider most relevant for the medical community?
I'd say there are several clinical messages. The first is that the clinical outcome of CRT is absolutely similar whether you have a CRT DX system or a 3-lead system. Whereas lead-related complications are significantly lower in the DX recipients. Means that the addition of an atrial lead in patients who do not require atrial pacing support is not neutral, is harmful. So everyone should stay away from implanting an unnecessary atrial lead. The other important thing is that along a consistent follow-up, and I recall that the first implanted patient at a 6-year follow-up grants that there is no sinus, no disease developing, but in a minority of patients who receive a DX system. We had only a single patient who needed atrial pacing after 4 years, becoming an octogenarian. Means we can safely use a CRT DX system for almost everyone.
What clinical competencies do clinicians need to have or to develop to successfully use this 2-lead CRT system?
The skills required to select a suitable patient for a CRT DX system is very low, and it is available for every cardiologist. As per the NEXT experience, the screening of a CRT D recipient is very simple and consists of the resting ECG once the patient has reached titrated beta blocker or ivabradine or both dosage. If the resting heart rate is higher than 45 beats per minute, then the patient can be safely implanted with a CRT DX system. For those having a resting heart rate below 45, evaluation of the heart rate achieved during a 6-minute whole walk test is the key. If the heart rate during the 6-minute walk test is higher than 85 beats per minute, then there is no or very minimal chance that the patient will ever develop sinus node dysfunction requiring atrial pacing. The other cases can be indeed considered for atrial pacing support, but this turned out to be no greater than 2% of consecutive patients being screened. In the clinical management of heart failure patients, it's very common to have load of data available before implantation. This is typically from Holter recordings or from telemetry recordings, which clearly point what is the maximum heart rate achieved by the patient. So there is no really specific test required, but the simple evaluation of heart rate at rest or during exercise as available per the clinical workflow of these patients.
What should be the next steps to further exploit the capabilities of CRT DX?
For sure, all the technical and clinical outcome of the NEXT point to a behavioral change. That is, once you see a CRT candidate, first look whether he has truly a need for atrial pacing. If he doesn't, or she doesn't, then the first line approach should be a DX system, which is just the opposite. Why do we say so? Because indeed we had no adverse event related to bradycardia or short, long, short sequences in the CRT NEXT. There were no ventricular arrhythmias induced by bradycardia events. So if you couple this with the clinical outcome being identical in the two groups, you clearly can turn a non-believer into a believer, because there's no role at all for adding atrial pacing to a CRT system.
What makes CRT NEXT a powerful clinical study?
This is a very important question, because if you look into the data of the NEXT, the outcome of CRT is very good. We have a yearly mortality of 4%, which is 2.5% cardiovascular mortality. So this is in line with the best CRT trial published recently, just like the ADAPT response trial. And we have 77% of patients becoming responders by echo. This witnesses that the newer technologies available in the control arm really improved the quality of CRT delivered. On the other side, these devices also provided the best suites for preventing unnecessary shocks and to terminate ventricular arrhythmias. So once you look into the data, the chances of inappropriate shocks is below 1.5% per year, which is even better than the pain-free SSST trial. And this is for both arms, the CRT DX or the 3-lead system. So definitely this points at the NEXT as a benchmark, state-of-the-art quality CRT trial. Secondary, medical therapy was very good because more than 90% of patients were on beta blocker or ivabradine, 13% were also on amiodarone, almost 95% had ARNI and Entresto converting enzyme inhibitors, mineralocorticoid sparing agents, blocking agents. So definitely we have a comprehensive approach to heart failure treatment that granted the clinical outcome. And we need to realize here that we have consecutive comers which are quite elderly compared to previous CRT trials. The NEXT population is on average 2 to 3 years older because they are unselected patients. This adds on the reliability of the comprehensive treatment that these patients received.
Based on the data available today, what percentage of patients can be treated with the CRT DX system as a first-line solution?
As from the CRT NEXT data and from previous experience, at least 98% of CRT recipients do not have atrial pacing needs. So indeed, they should receive a CRT DX system rather than a 3D system.
How could the CRT NEXT study results change clinical practice of CRT?
This can definitely change the approach of the average physician performing CRT implants, because they should select a DX system for as far as 98% of recipients who do not need atrial pacing. That would save complications and patency of the subclavian vein, which can be used at later stages for any other use.
What is the take-home message of the CRT NEXT study?
I think the take-home message of the trial is that you can achieve similar clinical outcome in CRT recipients, whether you use two leads or three, but lowering the price that the patient has to pay in terms of complications with the DX system. Remember that having a 4% repeated interventions means risking infections related to an unnecessary lead. That should make everyone aware of the risk he is posing to his own patients just to add a lead which will not be used. 98%, 99% of patients at follow-up means creating unnecessary harm to a patient who would live happily thereafter without an atrial lead.
Please describe the results of the CRT NEXT study with 3 adjectives.
Innovative, revolutionary, and visionary.